let's just start the process here. Would you be willing to start? Okay. Hang on a second. Oh, going around the outliners. Okay. I like this coalition of outcomes about participation, but that participation needs to move beyond just walking and rolling.
So, I'm sorry, could you say that again? Because even with the microphone, I couldn't hear it all down here.
Okay, so I like that the outcomes, many of the outcomes are about participation, and that participation is getting us moving beyond just whether we're walking or rolling.
Right. Okay, so you like that many of the outcomes are about participation in society, really, not just moving, walking, whatever.
I stole the mic because mine's actually quite related to that idea of the participation came up very frequently as an outcome measure of interest. And one thing that came up in our group that I thought was interesting was the idea that it's not just the persons with CP or their families that are impacted, but it's sort of a societal question too.
Okay. So again, the participation, is that what you're getting at?
Right.
Okay. So we have another one on outcomes included participation in society.
And that stakeholders extended beyond just the families.
Okay. All right. We may need another scribe. Let's see, because we got it. I'll do it. Otherwise, I'll do it. Thank you. But you could, we'll just switch it. Okay. I'm going to work for those here, though. That's great. Okay. Leave a column. Column on the right. Column on the left. Okay. Next person. Go ahead, Susan.
Okay. Well, I have many, but the one that I'd like to share is...
I'm sorry, microphone closer.
I have many takeaways, but the one that is, I think, probably most, the biggest one for me was that cerebral palsy is the most multidimensional condition out of the 35 that I've studied so far during my more than 30-year career with regard to doing studies. In other words, you really can't, with cerebral palsy, think that you're going to get very far in terms of improving care by just doing something for one age group and one treatment and one outcome. This is too multidimensional to even have meaning in any other way other than a broad section, cross-section of patients, treatments, and outcomes.
Okay, so cerebral palsy is the most multidimensional, must have multidimensional answers here, or answer would be the word. Multidimensional approaches. That's right. Next person, please.
So this is coming from me as a pediatrician, a developmental pediatrician, and maybe everybody else took this away a long time ago. But what I've taken away from this is just the importance of the adult perspective in terms of adults with CP, and that when we're studying this, even though there are some questions that will focus on childhood or infancy or whatever, important to maintain that long-term perspective in terms of our studies.
Okay, thank you. So the importance of the adult perspective in the whole field of CP. Does that capture it? If I'm not summarizing it well, let me know, because that's what's going to go up. Okay. Got that one? All right, thank you. Next person.
So mine is called having always been a pediatric therapist and now a pediatric researcher, I've been really
and met in this conference. I'm so blessed to be here and know that the support and ongoing research is going to help patients with CP to live more active and independent lives. And I think that's what I took away from this, is that the underlying current of all of this research and all of our efforts is to help make sure that from the time that they're small until they're into their adult declining years or growing older, that they can be independent and they can continue to participate in family activities or social activities, whatever it is that makes them feel most comfortable. But that independence and participation are very, very important parts of their lives.
Would you agree that that's one about participation, full participation, or the appreciation of having high expectations? That's the other thing.
I think I'm going to go with high expectations from an educational standpoint.
Okay.
An appreciation of the importance of having high expectations for people with CP.
Well, my first takeaway is 10-year-old sucks. I think what we need is a communication base. And we have a lot of research for it, like, you know, but we have no compilation of research where we can go find it. That's been my frustration all along. That's why I'm here, is because we don't know what's out there. But I think I've learned a lot about what's out there. So we need a clearinghouse. So clearinghouse for information.
So is that the main one? Because you were curious about the first, but I heard one in there too.
Yes.
Okay. So these are clearinghouse. Is it what the gentleman down there was saying about more focused collaboration?
Yes.
Okay. Let's put that under, that's the second one on that then.
I thought there was information out there.
Yeah, they are different. Yes, but you really need a clearinghouse then. I'm sorry, I lose you. So that is a separate one. The need for a clearinghouse of information related to CP.
I appreciated the importance of having all the stakeholders present, and particularly listening to parents and adults with CP, but I'd like to add that perhaps the stakeholder that we're missing are the teenagers and young adults that may have a different voice than their parents' voice, what they might want to express to what their needs and participations are.
I'm sorry, I was chatting with Paul. Can you summarize that?
Yes, I was just summarizing that I felt there was a stakeholder perhaps missing with the teen and young adult population, that the parents are advocating for them here at the table, but I think many of them have their own voice to what they would think their needs and participations are.
Okay, thank you. So there's a missing stakeholder group from the table, the teens and early adults with CP. I'm going to come back to Paul.
So I think my takeaway is as focused as I was on getting this patient-centered research agenda, I am fairly blown away by something that Picori pushed that I felt like we had, but I now feel like we have even more, which is just to have an engaged set of both members of the community and clinicians on both sides. And they're, you know, I just am, it's just great to see everybody just so either passionate to be here or so passionate to like have this new perspective in their work has been a pretty big aha.
So an even greater appreciation of the need for engaged partnerships. All right, an even greater appreciation of the need for a very engaged, true partnership.
So I guess I would follow up on that same theme, and that reflecting back on the process here, and the old way of doing research, of course, was researchers would get together, maybe singly or together as a group, but it would be researchers, and then NIDR and others said, well, you have to have a consumer in your group. So you'd have a token parent or someone, and I think they would be overcome by sheer numbers of the researchers and one consumer. So this is the first time that I've been in a forum like this where parents, consumers have been en masse, involved here. And I think it's made a big difference. My only concern is this is a grant-funded activity, and so it's going to be challenging to keep this momentum going and have the strength of numbers and perspectives from consumers really involved from the beginning of the research questions, which this is what we're doing, right through to the execution.
Okay. So another one around the greater appreciation for this engaged partnership. All right? Yes? Does that summarize it?
But you made a very good point.
I know, but there's one takeaway.
But the takeaway was how the team should be engaged. Like, so it's just some.
Will you say that's the...
absolutely.
Okay, so it's more about how to keep the momentum of engagement. All right, so let's... Thank you. Thank you. That represents it better. That's the kind of correcting I need. We're all biased. We hear different things. Okay.
So I've really enjoyed the process. I think that I'm leaving this workshop feeling very hopeful. I've been struck by, despite the fact that each of us is coming at things from a very different perspective, how much agreement. There's a lot of disagreement, but in the end, there's a lot of agreement in terms of what our priorities are and what they should be. I'd like to echo Jim's sentiment too, though, that I think that this collaboration, which is such a promising thing right now, needs to be continued forward, and we need to not only continue to work together, but to expand that. And I think a key part of that is going to be securing funding to put all these ideas into motion.
So which of those two is the most important? The latter, about keeping the momentum and funding going for this kind of thing? Or
I think so.
Okay. All right. That's another one on the momentum. 2 months. Go ahead and pass it down.
Hi, so this is stated a little earlier. I think my biggest takeaway is just how complicated and individualized this process really is, and how truly is very multidimensional. So another tally for that.
Okay, thank you.
First of all, I'm blessed. I've never had a professional experience like this, and I've been a therapist a long time and a researcher a long time. I think what I would like to say is that I now know as a clinician and a researcher that the full life experience of persons with cerebral palsy, not that I know it well or it's documented well, it's imperative that drives our care and our research going forward. As Dr. Staley said, our primary endpoint is the whole life experience, so that the teenagers, the young adults, those that are more seasoned in our life experience with cerebral palsy drive what I do when I'm working with a family of a 1-year-old.
Okay, so I'll just stop. Is it really about longitudinal studies and experience being sort of one?
Longitudinal studies should drive our research and our care.
Okay. Great. Thank you.
So I've been trying to think about, I feel like I can echo the majority of the things on that board, and I was trying to think about what the consolidating point is, and I think for me, it's really, as Susan was saying, to start the conversation about it being multidimensional, and I think it's really that we have to think outside the box. And Deb Hertz had been mentioning earlier in our breakout group, we need to propose the research that needs to be done, not just the research that fits the grant mechanism. And how do you do the longitudinal study? How do you get the funding? How do you include everyone?
What's your biggest takeaway? There's about 4 in there.
I think it's really that we need to come up with a unique way of doing research within the CP world, because we are so unique from every other disease pathology that I've ever worked with before. It's not just stroke. There's a million things that go into it.
Okay. So is this the need? Does this represent the need, or we have to come up with something else, a unique need? What do you take away?
I guess having this forum of everyone together, stakeholders and researchers, is the way to go about thinking outside of the box.
Okay.
But I think there's still a lot of steps to go.
to a board as to how you put it all together to make it actually happen.
Okay, so do you want to add a takeaway then? More steps to take out the box. This is thinking out of the box, is what I'm hearing. But I think there are also more steps.
I guess you can throw it into how do you keep the momentum going.
Okay. How do you keep the momentum going?
Funding going to, and it goes like underneath.
Yeah, these are all part of it. These are not. So let's see. Okay, next person.
So, like many others, I've appreciated all the things that people have said already, and I think I would echo the pediatric perspective in that it's been incredibly valuable for me to hear the stories of families and adults, and to hear, more about that lifespan perspective. And I think that what it's done for me is reinforce that the importance of optimizing care in infancy and early childhood, so that we get the best possible outcomes in every different way as people travel through their lifespan, and that we're getting
the biggest takeaway in optimizing infancy and early childhood care. Is that what you're saying?
But with that lifespan perspective.
Okay. So is that a new one, or do you see that there's sort of a twist on optimize early childhood and infancy with lifespan perspective? How's that? Okay, got a new one up there. Amy?
Well, mine is very similar to Jim's, but he represented the researcher and I'm representing the parent. I was one of those parents over 30 years ago who, started out being involved in groups like this, and I was the token parent, and we kept saying we've got to get more parents, and at some point we had, we said we have to have at least 2. And that was a big goal. And so, this is a whole new level. I'm just so excited to see all of the family members, individuals with CP, representing a whole range of ages, conditions, and I guess you all have CP, but, the different heights. And I just think this is so rich, and it has to be the new way going forward. So I just want to applaud also Paul and Melissa for putting this together, and I just think this is a whole new direction for us.
All right, so I heard that, and correct me if I'm wrong, that I heard that as, again, the greater appreciation for this new model, semi-new anyway, of a true partnership, not token parents, token people with CP at the table about research. Yes? Yes. Okay. All right. My green marker. Next person, Uni.
I came here to better understand the perspective of the people that we're ultimately trying to help. So people with CP and carers and parents with CP. I have learned a lot. I would echo what Lizette and Susan said. It's complicated, but I'm very optimistic. We've got large teams. We don't have to answer that entire team with one project or one question. As long as the debate goes down, I think we have lots of information from this process to go about doing this work in that truly engaged partnership that I think we've established. So I'm optimistic.
So is the takeaway the engaged partnership piece?
That's, I think, taken for granted. It's the optimism that we can make this work.
So you take away optimism that we can make this work. Okay. So we have optimized care, and I think it's a new one. He takes away optimism.
Optimism that we can do this work. So
that we can do this work in this
He's
manner.
pretty optimistic generally.
Articulation more. Okay. Did we finish on this thought or not? I'm going to surprise you and take it. I'm surprised those over there. This is a little trick someone taught me in facilitation. Don't go in order. People fall asleep. Part of my job is to keep you awake. So where was I over here?
So first of all, I really have to say I'm kind of between a few. I mean, my first takeaway I was telling Michelle this morning as a parent, I have no research background.
absolutely no medical history. I had a child who ended up being diagnosed with BP, and my Google MD kicked in, and that's how I ended up here. So when I came here, I wasn't really sure how receptive my voice was going to be on behalf of my son. And I really have to say, I think I agree with a greater appreciation for this, because this gives me hope that all that other stuff up there is going to happen. Like, we can come here, that like in our group, I mean, we were very receptive towards each other. We were respectful of each other. Everybody heard. We heard what each other had to say. And I think that's more important to move forward than anything else, because you can have the funding, you can have the best team put together, but if you can do research, but if it's not something that's going to be applicable in the real world and what people need, like the long-term studies, where are we going to go? So I really have to agree with a greater appreciation.
Okay. So I heard also, I mean, it's the same idea, and it's a bit of a twist, but not only is it an idea, you experience a true partnership here.
Yes, exactly. I'm kind of in between some of those, but I think just to stick with something that's already up there,
okay,
I would go with a greater appreciation.
Thank you.
So my aha moment, the cascading loss of function. From all that I have heard so far, my mind was like, okay, once it gets to adults, like 21 or 25, it's going to be cruising altitude. We can let our guards down at that point because they've matured, but that's not the case.
So the cascading deterioration was the one that really gave you the aha. You take it away with. Okay, Diana?
I have a young woman sitting next to me that I never had any idea what this person's doing. And I knew that she was listening to some webinar every Wednesday night because I had to set the computer up for her. So she said, yeah, I'm finding some research, something. Amanda's really involved in a lot of things. So she came to me and said, I need you this weekend to go to Chicago with me. I'm like, what? So it's the last day of school. I have all this stuff going on. So I came really as a support and as a personal attendant for my daughter. I had been very struck by my voice being heard because I wasn't really anticipating that. And I'm absolutely overwhelmed. I'm a principal in elementary school, a large elementary school, and it takes a lot to overwhelm me, let me tell you. I'm absolutely astounded and amazed at the amount of knowledge and expertise in this room. It's really, yeah, I just sit back and look at you. Oh my gosh, these brilliant people want to hear what I have to say. So I'm just so glad that you've included voices of adults, of children that have lived through this, have lived the life of working with children with cerebral palsy for any number of years, age right. And for our voices to count and to be heard is just overwhelming. So thank you for that. Continue the collaboration. It's been a wonderful and amazing experience to be here, and I think one of the things that I've taken away from it is our opportunities as adults to be voices and sit at the table for those people that we might know in our communities that don't have these kinds of opportunities and don't have a voice to do this, and how important it is to listen to what they have to say as well and bring it back to the table. And I don't cry.
Amanda, is the takeaway then about appreciating the partnership?
Yes.
Yes. Okay. Thank you. April?
I'm here as a caregiver for Kathy. I was shocked when I was asked to come. I've only worked with Kathy for a short amount of time. I had no idea what I was walking into this weekend. But I have learned a lot. I've learned that it is important to do the participation and to see where their life expectancy will go.
So which of the two of those is the most important? About participation?
Yes.
The participation in society?
Yes.
Okay. All right. Thank you.
Okay.
What did she want to say something?
Did you want to say something? Oh, just that her outcome was the great experience, the great experiences that she's learned and the expectations that she can take back to her housemates and fellow staff, along with myself, and to let them know that the research is going forward.
Okay. So that's an appreciation for what's happened here.
Yes.
Great. Thank you.
Okay, I guess my biggest takeaway was I was truly impressed with how clinicians and researchers and parent advocates and the adult health advocates and its facilitators, how everybody respectfully listened to one another and collaborated with each other. And I think what we got is a major first step into developing future research that will actually have a lot of daily practical applications for people with cerebral palsy. So I'd just like to say thank you.
So I'm sorry, I didn't quite hear which was the most important in that to you. I know it's hard to just pick one.
Set a good foundation for future
Set a good foundation.
So appreciation.
Was it an appreciation for the partnership, or was it really that it's setting the foundation, that a lot was accomplished in setting a foundation?
That was only possible because everybody sitting around the table was very respectful and courteous to one another, listened and collaborated.
That's listening. So that is a part of that. That's what I would call true partnership, a greater appreciation for the true partnership, which means active listening, really hearing, really not being a token person, that kind of thing. But are you saying something different? That's what I'm asking. Or is that it?
Both go together in my estimation. And that's because what we did here was a good first step.
Partnership. Thank you. I'm sorry, we're sort of muttering back here trying to figure out how to translate it. Thank you.
So mine's a little weird. So my aha moment came
The microphone, Diane.
when I was looking at the research team. I started my research career 25 years ago doing exercise and CP, and then I decided, well, that's so obvious. I'm going to go and build robots and do brain imaging, other safe stuff. And I think our field is sort of also looking for that big bullet. But if you want to take one thing and really make a difference, exercise and physical activity, if we could figure out how to make it accessible to everyone, no matter what their level, what their age, do it safely. I mean, it takes, if you look at the things repeated, pain, fatigue, endurance, the negative effects of aging, exercise, mental health, cardiovascular health. I mean, we're going so far, but maybe we need to get back to basics and really think that the physical activity may be the simplest one win-win solution for a lot of
So your takeaway is the importance of physical activity.
Yes, and I think it's important about how to get rid of pain and how to make life better. From a musculoskeletal standpoint, it's probably nothing better. You know, we've tried a million other things to do. It's a win-win.
Thank you. Thank you. Okay.
From the background, I think appreciation that child outcomes and adult outcomes may at times be in conflict and not the same, and that the longitudinal, really a true longitudinal registry of outcomes may be key in our identifying the key sensitive periods for intervention to improve adaptation and resilience.
So what's the most important of those two? Because I heard two for sure.
Yeah, I think to think global and act local so that everyone who's struggling to keep engaged with their partner should do that at their individual sites and be sure that that's included because everybody's going to be scattered out, even though we're in a network, that we need to continue to struggle for that longitudinal.
The longitudinal keeps coming up. Is that the one you're saying?
Right, and I think you also keep engaged.
Yeah. I know you're trying to get them all in there, but that's not on one. Most important.
You always put your God on one.
Yeah, it's longitudinal. I heard it 3 times. 3 wins.
I'm going to full disclosure here. I've been a PCORI patient reviewer for the last and mentor for the last 4 years. So I know how successful it is when you get the patients talking with the scientists and the researchers and the clinicians. It works. But now I'm on this side of it, and I can even see how valuable it is to have the different perspectives, to have the parents and the patients and the caregivers speaking with clinicians to get all on the same page. And it's a valuable way to move ahead what we're trying to do here today. So the collaboration.
Again, the greater appreciation for a true partnership, really getting down and gritty with each other for a true partnership. Okay, here we go. I'll come around.
I'm getting a lot of exercise.
I'm getting back.
You ain't had exercise, man.
Thank you, Deb. It's nice for her to do that, especially when I get the steps more than she does.
Microphone, Michael.
I decided to stretch.
Microphone closer, please.
It doesn't get much closer. I used to be a lounge lizard, so I know how to use a microphone. Flying to the moon. Having been somewhere near the end of this, I'm actually shifting my takeaway with your permission. So many people have said pretty much all the things I was going to say. Comments about passion, optimism, remember the adults, we can do this, etc. My takeaway is a bit, I'll be dark. I'll say, but be prepared for some disappointment in this process. And I'm going to divide this into 2. So I get 1, but it's 1A, 1B.
No, they don't get up there.
Something makes or breaks this. We all know that. I'm not coming and anything. Oh, darn, you're that. All right, so that's something. No, really. But I can't imagine. There's so much that we can do. That's the optimism. But it's got to get paid for. This will be expensive.
So is your takeaway then the barrier of funding?
No, my takeaway is be aware of the potential for disappointment. Number 1, some stuff will get paid for, some stuff won't. And 1B, I think, I say this, especially listening to patients and families and advocates, when we start on these kind of processes, you remember, or you have to remember that it's really hell to live on the cusp of some big advance. If my great-great-great-grandfather died of appendicitis or a streptococcal infection, I'd say, yeah, well, that was the 19th century. But to die of something today when that antibiotic, drug, whatever is just on trial now is really hard. I think the adult patients, families, caregivers, it has to be recognized that we're going to learn, but that their greatest benefits will be applied to subsequent generations. And unfortunately, if there's I came to this meeting for the cure, that won't be. And it's one of those things about, to make something of the disappointment, you're the source for and the way for everyone else to learn. Biggest thing with already being said as a takeaway is registry. We need to collect the data.
Okay, hang on. You got about 5 in there. I tell you what, be prepared for disappointment.
Right.
Correct?
Especially funding, and we may not change the lives of today's
Okay. Be prepared for disappointment, funding, and
Well, I said it, but in a positive way. I didn't appreciate it.
All right, next one. How many people have not gone? I've lost track of 4 of us. 4. Okay. Take it away. Thank you.
So I have to agree that this has been tremendously inspiring, and I do think that it is absolutely required that we have the collaborative partnership going forward.
Could everyone be quiet and listen, please, and engage listening?
My main takeaway especially from our discussion yesterday in the small group and then this morning,
was that we need the sort of the concept of what some other fields have done is the common data element, so that we collect the same amount of information about every baby, and if we don't meet them if we meet them when they're 5, we go back and get that information. If we meet them when they're 50, we get what information we can, and then follow people with standardized outcomes, because we don't know right now what causes pain when you're older, what interventions we do will have what effects down the road. So we need to collect a broad amount of information about everybody and track that going forward. And that reflects the multidisciplinary aspect that everybody's been talking about.
So summarize, is it about registries? Is it about longitudinal?
It's all together.
Give me a summary of your one main takeaway.
It is a common framework that includes the initial data coming in, as well as collecting your interventions along the way, as well as looking at standardized outcomes.
Is that different from longitudinal?
Well, because like longitudinal may be just looking at your motor function in 20 years, but I'm including mental health and pain and quality of life and everything together.
Common data elements?
Yes.
Would that summarize it? Thank you. Okay. Okay, what?
I appreciate the collaboration between the parents and the people with CP and the clinicians. As a parent, it makes me feel very good to have a voice to speak on behalf of my child. I did find that there seemed to be, and I may be way off, a lack of continued care between adolescence and into adulthood. And I didn't know if there was more care in that time and then continue through adulthood like we do for the peds. If that would affect, the outcome of the quality of life and prevent deteriorating. So I guess, yeah.
Is that a missing stakeholder then, as well as missing focus? Stakeholder and focus on teens and emerging adults or young adults?
Right. I would say that, the missing stakeholder. We need that voice.
Okay. Okay. So there's two on that missing stakeholder and related.
One of those issues is transition, right? Is that what I heard you say?
Right. Exactly.
Okay. Thank you.
As a pediatric clinician and instructor in an occupational therapy program, I am just, I'm in awe that I need to include this as a lifespan approach. Cerebral palsy is considered a pediatric condition in occupational therapy when we teach it, and I sadly have not really discussed this, although I'm new to the faculty, really discussed this with the adult physical disabilities instructor. And although I have a brother and I have observed the lifespan of cerebral palsy, and that's why I do what I do and why I'm here, and I've wanted to tell his story. Being with all of you who are a voice for those who have no voice have validated that and confirmed that listening to your story should guide my work with children. And that when I think about content validating what I'm doing, and, is my construct defining, am I defining the needs of individuals with cerebral palsy? I need to talk to you. So this lifespan approach at all levels and all ages is just, I'm in awe. And I'm grateful to be here.
Okay, so I hear I heard about 5 times the word lifespan. Do we call that the summary? Okay, thank you very much. Anybody else? Yes. Please, Amber.
I just have to say that I am so grateful to be here in a room with so many people of rich backgrounds. It's such a blessing. And my takeaway is that this is the beginning, and I hope that we are able to come together again to do more. I feel like we need to share more as an adult with CP, giving the information to clinicians and to everybody. And as a clinician, I want to hear more too. So I'm grateful for this collaboration and look forward to how this is going to evolve, because I'm very optimistic that it's going to just grow.
So the takeaway has several things in there, but I hear it as mainly about the keeping the momentum. You're looking forward to the momentum of what the results are with keeping this moving forward. Is that right? No. I can tell by your face. Help me out. What's the main takeaway you have? Was appreciation, but I'm not sure that was it. I think that's the partnership. Let's let her define it.
The optimism, I think, of where this is going to go.
Okay. So we're on optimism that we can do this and move forward. Okay, thank you. We've got a few more down here.
And I have one online when we have a chance, and I will keep for.
You have one online.
I have one online.
Cool. We have people listening in. Yay! I love it. Yeah. Okay, and there's Amy?
Yes, there you go. I would like to turn. Thank you very much. So, when I walked around and looked at these again, I'm a physical therapist also. I don't think I said that before, and a researcher in an outpatient clinic setting, so not in a faculty school teaching setting. It's an academic hospital. Anyway, when I walked around and looked at it, the things that stuck out to me were if we could say what we need to do all in one sentence, it would be we need longitudinal studies that compare things with the focus on function and participation in adulthood. However, it comes to my attention, I can only say one of those concepts.
Thank you. She's describing clearly.
Longitudinal studies. Here's my vote.
Okay. Thank you. Anybody else who's physically here who has not spoken? All right, then how do we do the online person?
So I have just asked, I just asked John whether or not he didn't respond as to whether or not he'll say it. So rather than you hearing John's voice, I will speak so we have. So John, I'm doing this for you. So this is a comment from John Borland, who spent the better part of his day yesterday listening in. Was disappointed to not be able to participate in breakouts. John is a member of the Community Advisory Committee for CPRN and just felt like travel would be too difficult. And he's an adult with CP. Thank you, Michelle. And John said, I will say I'm encouraged, but rather surprised that it has taken this long to get to this comprehensive dynamic with regard to CP research, with the involvement of clinicians, researchers, patients, and caregivers, and was looking at CP across aspects and age. I did not ask him to consolidate it to one, but I wanted to share his statement.
Want to get it up here? Are you including people online in your?
I don't have a mechanism to do that, but I want to share it because he's invented it.
Okay. All right.
Thank you very much. And believe it or not, we're on time.
Oh, I'm so sorry. That's right. You had to step out during a lot of this, and we arranged this before.
Well, thank you, everyone. I'm really glad to be here, participating in this exchange. What I feel is that somebody told me before, it's going to be, it's difficult. It's difficult. Like when I was here as a parent, I heard emotion, like people were crying and how to translate that. It's difficult how to, and I think it's going to need I think about paradigm shift, or maybe, as you said, think outside the box. And maybe it's a really optimistic project that we are in today, but it will need this step, think outside the box for both sides. That's what I heard. That's what I learned to make this happen. So thank you.
So have I got it right? I heard that as a concern about how to keep the momentum going, how to, in the face of obstacles coming ahead. Is that right? No. Yes? No.
And thinking outside the box?
Yes. And thinking outside the box. That's part of that one. Yes? Okay. Thank you very much. We are exactly 11 o'clock, a facilitator's rare delight. So we're moving on to, oops, our agenda fell down. I'm going to get other paper down. All right, now I'm going to hand it over to the people who worked on this, because we're going to do the walkthrough now. Please do. We've done it. Okay. All right. So we're moving on to our last, not last, we've got several things over lunch as well, excuse me. But the next piece is walking through of where organizations might go with example research concepts that were developed yesterday. Okay?
On the wall while you do that, or do are we just talking?
I think we're talking. Okay. Thank you. All right, so do you want to introduce a little more on that and the people who are going to do it?
So one of the things we were trying to respond to when we were talking about last night is several, and it's really come up in this sort of key takeaways about how we move this forward. But I think it may have been embodied in what you said, June, about sort of how do we, how does this kind of turn into something other than it's a good set of questions. So what I wanted to do was give people a sense, and I figured I was going to start with R1, C1, and R2 as examples, and to say, okay, so now we took out all the things that we wrote, so I may have to work off of the raw, unnarrowed version, but I want to take that and give you an idea of, based on this work, like how will this actually come to fruition? Like how will it go from being a concept to a question to a funded study with an outcome? Because that's really what we want to see happen, is we want to see this. And so part of what Michael Partington was saying was, you have to be prepared to be, potentially disappointed at one level, in the sense that this is very big, many of these questions. And what will happen in the process of taking it from a concept to a question is it will get narrowed. But that doesn't mean that it's not, super meaningful and impactful. So if I take R1 for an example, which is what are the best long-term exercise strength training strategies to improve activity, participation, and health, minimize pain, maximize function in each CMFCS category across the lifespan. Now, that was in the black group, and I know that the core thing that we did with that was sort of collapse maximize function and participation to say, activity to say activity/function. But other than that, not very modified. We had a researcher in our group, Patrick McPhee, who is working on his PhD with adults. And I asked Patrick, so Patrick, could you describe a little bit about how this question would get tackled from your perspective? So one of the things I want you to understand, for any one of these, what has to happen is we've all expressed our passion about this, and that's great. Then it needs to get down to, not necessarily someone in this room, but I will use examples from this room, but someone who wants to really drive and lead this effort, and then find the support infrastructure, of which the support infrastructure is the clinical sites, if it's a clinical study, if it's the patient-reported outcome methods, if it's going to rely heavily on that. It's the, how all the data coordinating is going to happen. What's all the infrastructure necessary to actually turn this into a study, submit it to a funder, have it get approved, and get studied? So, not that that's too much pressure, Patrick, but I'm going to hand you the microphone, and we can go back and forth, and then you can talk about how you have one of these outcome areas is very specific to your research. So if you could just give an idea of like how you would have to narrow this, and I have a copy of it if you have the question right there. Yeah. So.
All right, thanks, Paul. This is quite a task. It is an R1 question, so it has been voted on as being very important. So we do have a question here, and then the next step is, how do we sell this? How do we get money to answer this question? And when I think about research and writing grants, I just kind of started getting my feet wet in doing the whole grant submission process. But an important thing is to identify what I call a knowledge gap. So what do we know and what don't we know? What are we trying to answer? So I'll give a quick background in terms of exercise and strength training physical activity in the population of people with CP. So a lot of research in this area has been fragmented by studies that are small sample sizes and that are geographically isolated. So if I conduct a study in Hamilton, Ontario in adults with CP, for example, I did one in 42 adults with CP, what is the external validity of my results? So that's a fancy term of saying how generalizable is it to everywhere else in the world for adults with CP? Because I just took people from Hamilton and ran this study, is it going to have the same outcomes in California or wherever else? So I think one thing to identify in the research is that these small sample sizes and that are geographically isolated, to answer that we need to do something that is multi-site. So I think being here and having CPRN here present, that's something that they could help facilitate is who else wants to answer this question? Clearly everyone in this room because it's ranked R1. So figuring out who other institutions that are equipped to answer this based on these outcomes. So improving activity, participation, reducing pain, increasing function. So those are all important outcomes, but what are, I guess, tangible ways to do that? And that's what fell in the second column, the what or the how. So going back to the research and the literature, what's one type of training mechanism that we can use that everyone with CP can do? I'm trying to think of studies off the top of my head, and Ed Hurwitz, who did a nice presentation yesterday, he was part of a study that looked at, I think it's called a recumbent stepper, which is pretty well a seated bike that you put your feet in, and it's almost like an elliptical, but I think in a seated position. And him and Mark Peterson from Ann Arbor validated that in GMFCS levels 1 through 4 in adults. And in research in my area, level 5, or sometimes it's unfortunate, but they're deemed the forgotten 5. So it's hard to include that GMFCS level. And so we need to find a way to do that for measuring these outcomes. And that would be a knowledge gap that we would need to answer and set forth in this grant application. And there's also, going back to the literature, there was a nice review written in Developmental Medicine Child Neurology last year that Ed Hurwitz and Mark Peterson were involved with, and the lead author was Lola Verskuren, and it came up with physical activity recommendations for people with CP, and it was in children and adults, and it was synthesized from what studies have been done in these populations with CP in children and adults around physical activity and strength training, and they came up with a set of recommendations. I'm not going to call them guidelines because they weren't evidence-informed, the recommendations for people with CP to improve physical activity. So that was in, like I said, developmental medicine, child neurology. So something you could take from that is, can we take those guidelines and test them and see what the outcome is? And it could be through, based on this question, it might be through an intervention. So if we go to the gold standard of randomized controlled trials, could we set something up for that? And I think that I might ask Susan to comment because she did that nice webinar on efficacy versus effectiveness in terms of what study needs to be done to answer this question. Is there anything else you want me to add?
So how would you envision engaging the community either pre, during, or post? I mean, clearly they would be saying.
Louder, Paul, can we hear it?
How would you recommend engaging the community in attacking the study? What role would the community play in the planning as well as the execution?
So to answer this question, I think it would have to be prospective in nature. So we would have to recruit people with CP to answer this question. This isn't something we could go and retrospectively look back on a data server to answer this question. So finding people in the community that would be willing to participate in the study would be one path. And again, I mentioned CPRN. I don't want to call them out, but they would be very beneficial in, I think, facilitating some methodology to answer this question in terms of recruitment and investigators that are interested in answering the question.
Great.
I want to make sure also, so that we continue to be on the same page and understand each other. If there's a term in these presentations that you don't understand, a word you're not clear of, do not hesitate to raise your hand and ask. We want to make sure, because this is getting more into research-ese.
Go ahead, Christina.
So my question, because this came up in our discussion, yes, okay. So GMFCS5 is this, okay. So whenever you're looking at them, because we were talking about this, and there's different ways to gauge improvement or progress, right? So if you have a study like you mentioned with this effort, can you not incorporate, like, for example, being able to move their foot off the floor into their wheelchair bars, or, where the foot rests? Could you not interpret that as progress and improvement and gauge that somehow to incorporate them in that type of study or research? Or is it just that it's more, I hate to say work, but it's that where it comes down to where you're just trying to stretch that dollar to get more information for what you have? Is that fair?
Yeah, and I think maybe to answer this question, we might need to do a few different studies separated, and what the question says, in each GMFCS level. So you might not be able to compare the same
intervention for across all GMFCS levels.
Because what we kept talking about was wanting to do all GMFCS levels, and we kept, it kept coming back that that's why they usually stick, the GMFCS3s, and Chrissy was so sweet. She was like, very helpful with me, because I was like, but why? Why can't we incorporate? So.
And then Diane. Did you want to respond to this?
Well, I was just going to say, in some research with adults that I'm familiar with, and I've done this in my studies as well, is separating the population into two, so splitting it. And what I've done is I've deemed it community ambulatory versus community non-ambulatory. So community non-ambulatory being those who prefer to use a wheelchair to navigate through the community, and those who are ambulating. So that could be an idea, but I don't want to say forced, but I did that because I didn't have enough people in my study, enough power to separate across each GMFCS level.
You know what power is? I've hung around too long.
Someone asked the question, what is power mean? Power is that's a research ease word where that we have enough numbers of subjects to answer it in the mathematical statistical way. Does that make sense? Okay. So I think what we were saying, is to rephrase it slightly differently, is, again, bifunctional, what's important for children and adults at 1, 2, and 3 GMFCS level versus 4 and 5, or maybe the 3s over the 4s, depends on the question. And we can have them in the same study, but we have enough subjects in the study so that we can answer the questions with different outcomes by what's functionally important. So what's functionally important for the kids and adults who are walking is going to be different outcomes, and that's what I think you were getting at.
Right, yeah, because you have tight control, anyways, we can, I'm going to take it off.
Okay, Diane, I'm going to give you a chance to ask your question. Now I'm going to move, I want to make some clarifying statements and then go on. You're good? Okay. All right, so one of the things so Patrick is a passionate researcher, and he's done some single-site studies. So he talked about how he would have to shape this study question. So what CPRN is currently 18-center clinical research network created to conduct high-quality multi-center studies. It's not an easy thing to do, and so having an infrastructure to do that greatly accelerates getting it done. It greatly enhances your ability to get funding because there's belief in a mechanism for doing it. So what Patrick would do, because he's not at a CPRN site, is CPRN has a mechanism that an investigator that has a concept that they think is interesting submits it to CPRN. CPRN is going to look at this and go, wow, this is an R1. Like, this is top of the heap. Let's develop this to be a full protocol, to be a full study. And then we take our resources, like Susan and Jacob, who are part of our data center at the University of Utah, and we work with Patrick and others that he feels like want to contribute to this. And we get it to be a full study to be ready to submit it to a granting application, and we do that. And then that gets scored, and it either gets funded or it doesn't, and we may have to iterate. That's just part of the process. And it gets funded, and then we leverage. We now are 19 sites, and it's very easy for us to look at a study and say, hey, this is a great idea. This is something we can really leverage our overall infrastructure for. This is patient-centered. This is what everyone wants. Let's make this a priority. So it's really intended about how these things are going to get narrowed and then executed. And they will take time. Sometimes they won't get funded. Sometimes they'll have to get narrowed more to get funded. But that is a great example of how the top one is going to come to some level of fruition. So I'm going to use another example from this just so you understand. I need to find my list and find a biomarkers question, and if anybody can reference it quickly, that would be great for me. Thank you.
Very good.
So,
you want it right here?
That's fine. So identify biomarkers, neuroimaging, blood, CSF, amniotic fluid, genetics. Anyway, so I'm setting myself up. To help with that?
Look closer still.
To help determine which individuals respond best to which intervention, therapy, medical, surgical, so the treatment approaches can be tailored to each individual person with CP. So CPRN was founded at 17 sites. All the sites are actively working to build, to get the registry infrastructure in place. There were a number of other sites that we wanted to be in, but they for one reason or another, weren't ready. But they were very committed, and I just want to give another very real example, taking a little further along for C18. So Michael Kruger, pediatric neurologist at Phoenix Children's, had stayed in touch with us, said, we're really interested, we'll do the work to get our environment up and ready, and then eventually came to me and said, we've submitted the protocol for our registry, which means they've gone to get the governance approval to be collecting base level data, but we really want to work with you with CPRN to conduct a multi-center study that's effectively on biomarkers. So Michael, I want to give you a moment to talk about your area of study and how that went with sort of getting engaged with CPRN and where it led to where are you on the sort of funding to take this more narrow but very important area of biomarkers forward.
Thanks, Paul. And I think that our experience has been quite exciting for me. So Paul mentioned I'm a pediatric neurologist, developmental pediatrician, and so I see patients with CP all the time, and I'm very engaged with the clinical program at PCH. In fact, I direct it. But at the same time, we were interested in a research question that's a little bit of a step back from some of the work that's being done here. So we're interested very much so in participating in the CPRN and trying to be part of the process of finding answers for all the challenging questions that have been raised over the last couple of days. However, we're also very interested in asking a fundamental question about some of the causes of CP. And in particular, my research program is focused on the idea that in addition to the well-known causes of CP that exist, lack of oxygen, prematurity, stroke, etc., that there might be genetic causes of CP. And in some cases, for some individuals, those genetic causes could predispose to prematurity, predispose to stroke. And in other individuals, those genetic causes might actually affect the developing brain such that CP results. And so this is something that we've been interested in for the last several years, and we've slowly built a research program designed to try to answer these questions. This is something that in other fields, other neurodevelopmental disorders like autism, like epilepsy, for example, it's well known that there's a very strong genetic basis for many of the affected children and adults. It's been less clear in the case of CP, although the data is starting to look pretty convincing, from my point of view at least, that these are important contributions. And what's exciting is that, again, taking a step back, we might be able to make sense of some of this genetic information in a way that could, in the end, be very practical. It's a step further back, and it's going to take a longer time to realize than some of the exciting projects that are being discussed here. But the idea is if we could understand what causes neurodevelopment to go astray, or what might predispose a child to have a stroke or to be born premature, that might give us a completely new way to act. We might be able to modify these things in a way different than we're currently doing, different than Botox, different than surgery, different even in the medication choices that we have. And this is a very big picture idea, and I admit it's somewhat pie in the sky, but as Paul mentioned, we've worked very hard and very diligently and gotten a lot of feedback from a lot of people in this room, in addition to many others, to narrow it down. And so what our immediate focus was, and what I went to Paul and the executive team for, was for help. Because the number one limiting factor to do our genetic studies, we have the technology. I now have the team assembled that I've been working on for the past several years. We simply needed to have participants. We needed individuals with CP and their family to say, yes, we want to be part of this, recognizing, as Michael Partington very eloquently stated, that this may or may not directly influence the person who's participating. This might be something done for the greater good. In some cases, it could help inform a person's treatment, but in many cases, it might not. And so we've done this on a limited basis, and we've now sequenced roughly 500 individuals using a very cutting-edge DNA technology that's been applied to other neurodevelopmental disorders. But what we found has been what we feel is just the tip of the iceberg. So we came to Paul, and we came to the executive team just a couple months ago after forming an international consortium. So we now have researchers from the U.S., from Canada, from Australia, from Sweden, from China, united to try to answer these questions with a lot of support from folks like the CP Alliance and from Cure CP. And we went to Paul, as I mentioned, and said, we'd like to do this study on a grander scale than we've been able to do before. And I recognized that this was somewhat outside of what CPRN's immediate focus was. But nevertheless, I was struck by the possibility of collaborating, that together we could accomplish something much greater than I certainly could in my research group, including our collaborators around the world could by ourselves, by engaging with CPRN and engaging directly with the stakeholders. And I'm very pleased to say that although we're still sorting out that process and there's still a lot of questions to be answered, that I've worked closely with Jacob and with Susan, with Paul, and the rest of the CPRN to successfully submit. It hasn't been funded or not funded yet, but it's at least been successfully submitted, a National Institutes of Health R01 grant application designed to try to bring this study to larger numbers than would have ever been possible by our smaller efforts.
Can you say what an RO1 is? Since we have R1 up on the floor, but RO1 is a different thing.
Yes. In my world, an RO1 is the kind of standard investigator-initiated or research group-initiated federal grant. And so it's hopefully a step in the right direction in terms of continuing to build this research effort.
Thank you.
Almost a takedown for Paul, but I covered it. Okay, thank you, Michael. And so that is a great example of one of these ideas that's important to the community. A very passionate investigator formulating an idea, presenting it as a concept level, taking it all the way through. Now, what is required out of CPRN is really to be a graph catcher for patients that want to engage in this. So it's not necessarily the same as some of our other data collection, but it is a collaboration that gives the ability to really do this study in a way that you wouldn't be able to do in terms of how broad of a geographical base you could get to patients. So I'm going to give one more just example of this before I go on to one of the other ones. So Teresa Moulton is here, and she's going to look up at me like, but I'm having a side conversation. Wait, she heads up the research committee at AAPPDM. Which is a number of people that are members that are just very interested in research. And so there's been a dialogue going back and forth between CPRN and AAPPDM about, how can we collaborate? And we think we've really, and we're, frankly, CPRN is just defining how do we go outside of our, core set of people that we invited and what will be our mechanism of expanding. And we've really just hit upon this mechanism that we described. And so, not to put you on the spot, Teresa, but the idea is, if you had a study that you had a passionate investigator about that's just a member of AAPPDM, they're at an institution, but it really needs the power of a multi-center site, there's now a mechanism by which that investigator can come to CPRN. We're going to look at this list. We have a passionate investigator, a realistic concept. We'll take that through and move it forward. So this is just to give you an idea of how this agenda gets out beyond CPRN, gets to the broader community as a way that we need to find these passionate investigators that we can bring to the table a great set of engaged people from the community to actually move these studies forward. The Academy is going to get it, so the American Academy, which is way more than American Academy of Cerebral Palsy and Developmental Medicine. Lee Narayanan is the president currently, and he's going to give a presentation at lunch. So I want to do a little bit more on this. Let me just ask, are there any questions based on what we've described so far? Do you want to go ahead? Wait, I see two, so hold on. I'm going to let you ask questions by microphone. And you're both next to each other, which means I don't get as much exercise.
So I just have a question. So I'm a researcher, and I love this idea of sending something into CPRN. Do you have a specific format in how you want to present ideas to you? Like, would I send like a specific aims page for my proposed grant, or do you need very other specific information to consider us?
So as I said, this is somewhat new, and it's just an area of our standard operating procedures or governance that we're just finalizing. We've actually done the first half of the review with the whole investigator committee. We do the second half on Tuesday, but we've described it roughly, and we're going to go into more detail. So the standard operating procedures have a template that you need to fill out. There is a process, which is you come and you ask the executive committee as to whether or not this content fits with CPRN. If we say it fits, we invite you to present it to the investigator committee because we want all these sites to be engaged in the research. So we want them to feel like this is good research, this is important research. If they, give it the thumbs up of a 70% vote, it moves on to being developed into a protocol where we work with you to go and to do this. So there's a whole process, and there is a template. It's a 2-page concept that, if it gets approved, has to be developed into a full protocol. So there's a full mechanism. Go ahead, Jude.
This is very impressive in terms of leveraging. I really liked it. Just wanted to say that there are other buckets of research running that may never rise to the level that process. So I just wanted to make one recommendation that we look at the last exercise where you collected, key takeaways, and consider, there was an artificiality of that process. Consider asking people to voluntarily submit more of their takeaways to you so they can be incorporated back into the white paper so that all of the little buckets of research monies and other projects represented around this table also get to take advantage of that great thinking in a lot of projects that we will never even begin to anticipate, but will be unintended consequences of this process. So, recommendation.
Thank you. Someone please capture from the describing the side. I will say just to that, PPRN submitted a grant for $22,000 to $22,000 request to Pedal with Pete to actually do an adult patient-reported outcomes longitudinal study of pain and social and emotional issues. So which was something I think was definitely in our group. So that concept of not only looking at things that rise up to the R01 $500,000 a year bucket is definitely there. Claudia, let you ask a question and then we go on to the next part.
And I might need a little clarity before this first, but as these questions go on to the next level and become viable research questions, is there a way or is there an intention to kind of like tag them so that they can be monitored longitudinally through your organization and, identified and then warehoused within the organization kind of as a foundation of future work that could possibly result in studies coming off of those studies and then people being able to access CP information within the registry that you're starting in?
So I think what you said is, the answer is yes. I mean, the whole idea of CPRN is to be a research enterprise that enables more and let the thousand flowers bloom. And, we've been discussing our data access, standard operating procedures, and say, what is the right way for us to maintain the integrity of the data, but let the brilliant ideas come to the table? I talked in our group about the concept of ways in which you can create what are called de-identified data sets. So data sets that have no information that can be traced back to the person, yet that data set can be linked with another data set. I was giving the example of the Vermont-Oxford network, which is this huge, over 1,000 center neonatal network, and I've been talking to them that if there's a way to link our data set with their data set, and then you would get for all the kids that came through a NICU in these 1,100 sites, you would have their history and be able to connect it to what we're seeing them once they have a diagnosis of CP and do that. And so the whole goal is to create a mechanism that is leveraging. And I personally, just as a kind of, set goals and then measure yourself against the goals, will certainly be taking this list and seeing where they go, how do they get done, and feel a personal obligation to report back on them. So absolutely. Okay, I want to turn to the next one on our list, which is C1. So I'm going to read you C1. which is research the issues around aging with CP to understand not only how to treat adults now, but also to update our treatments and therapies with children who have CP to prevent some secondary impairments such as pain, disease, and functional loss. I think this was worked on by the Blue Man Group. I'm sure it was not just men, but Mr. Blue, trying to humor it. So I asked Gary Norris, who is one of the leaders in CPRN, and Jacob Keene, who is also another leader in CPRN, to talk a little bit about their discussion of how they narrowed this and then how this might actually get actualized as a study.
Control this again. I apologize. Bring her notes. All right. Yes.
You want the text of the question?
Yes, please. I feel like I'm on Millionaire or something. Research the issues around aging with CP to understand not only how to treat adults now, but how to update our treatment and therapies with children who have CP to prevent some of the secondary impairments such as pain, fatigue, and functional loss. Okay. So kind of what we talked about, and I think we were lucky to have Russ in our group. We were kind of all aware that CP, a static disorder, nonetheless progresses. So, like, go figure, right? And where it progresses, it seems a lot of the time is in late adolescence, early young adulthood, maybe even to sort of older young adulthood, and just somewhere where about my age, where it seems like function can really drop off. And so we had this discussion just a little bit ago about GMFCS and, can you change, if you can change a function if it's important, like being able to get into your wheelchair easier, how do we measure that kind of thing? So GMFCS is not sort of for measuring smaller incremental function. It's sort of like a bigger bucket of things. We have other measures like the GMFM, for instance, gross motor functional measure, which might measure some of those things. But where we decided we wanted to focus was that, number one, we were talking about quality of life, but specifically motor quality of life. We knew there were lots of other things that go into a person's quality of life, but if you've lost significant motor function, especially so much that you've lost a GMFCS level, somebody who was ambulatory is no longer ambulatory, that's a big impact on quality of life. We wanted to focus on that sort of motor thing. For the WHO, we want to understand more about that group of older kids, younger adults that are in that sort of transition phase where they might lose important function. And we know from the GMFM measures that they often do lose function. Now, the sort of corollary interesting thing about that is that at the same time that we're churning them out of pediatric care into adult care, losing the sort of nestled services of pediatric care into the Wild West of adult care, as well as big changes in services that are available. Insurance, whether they're a therapist who can see you or not. So there's a lot of transition around that. So that's where we didn't put an age necessarily, but we said, older adolescents, younger adulthood. And we want to know what treatments and preventive services, the type and frequency of them, what kind of therapy, how much therapy, what kind of exercise, how much exercise could help someone maintain motor ability when so many people lose it at that time. So just a sort of thoughts about how we collect data in CPRN, or how we plan to collect data in CPRN is, so I run it at our hospital, and it's a longitudinal study in that all the patients come to see us every year. We collect the same information on them year after year after year on those same patients. And it started at my hospital even before I got there. So we have something like 7 or 8 years of data at this point. This has grown quite a bit, and the scope of it has grown quite a bit. But we have, again, I can tell you that this is something Mary Jo and I have been talking about working on. So in the communication functional measure, we have 8 years of data of what did they change over time. And that's the kind of thing that you can only get from longitudinal studies, is knowing, did this person change over time? Or did these people change over time? So we hope to collect that at the 18 sites. Again, it's a de-identified data set, but we know that, patient 1, this is what happened to them over 20 years. I mean, to me, that's the scope of what we're looking at. Is in a generation of people with CP, what happened to them. Now, hopefully we'll learn things along the way and make better care along the way. But even that, we have this observation of what happened over this big period of time. Did I leave anything out you think?
No. Any other Blue Group members? Thank you. Any other Blue Group members? Is there anything else that we should add to that? Deb, Ross? Anything?
Yes.
It seems to be a key number.
Let us get you
Not a moment.
I think a key member of our stakeholders should be people that follow adults with cerebral palsy, because I think, in all fairness, a lot of the centers are going to be children's centers that need to make adult connections, right? So I think we have a lot of patient-reported outcome measures for adults. Having the pediatric centers started, we need to make that important linkage to get adults who sometimes are hard to find, and that's even in Chicago, where I'm happy to be at a center that sees both adults and children. So it seems to me we need to get that linkage of how you really get the adult outcomes connected to those kid outcomes, right?
So I'm going to address this. Did you have something? So I'll address that, and I want to comment on an aspect of what Gary said. So let me just address that to say, so it is true that many of the centers within CPRN are pediatric centers. There are a number of lifespan centers, but one of the capabilities that I talked about in sort of summarizing CPRN is this community registry, which is this key thing that we are going to be able to link to the pediatric registry. I won't go into the technology details because I start to use words that sound like they're out of Star Wars and things, but there's a fairly simple way to connect and so that we can end up following people into adulthood wherever they are in the community. And if they're in a lifespan CPRN center, great, we can continue to collect clinical data, i.e. data that's reported by the clinicians or physicians that are treating these people, but we can also collect these patient-reported outcome measures and still link back to, well, how much information do we have about, what their roots are and where they started. And that's, so I agree, that's a critical capability, but I'd also love to expand with lifespan centers or adult centers that are, treating. And as you know, Deb, we look forward to getting the Shirley Ryan Ability Lab on board as soon as possible. I want to spotlight something about what Gary said. It's really Gary Norris and Nationwide Children's Hospital, because this is probably not something I've gone into much detail about, but a lot of the experiences that I bring to the table in CPRN come from my experience in building another registry and another clinical research network for hydrocephalus, which is another neurological condition that my son has. And that currently has a registry with about 6,000 unique patients, over 10,000 surgeries, because it's a surgical registry, so it captures demographics and surgical intervention. And when we did the NIH workshop back in 2014, Gary and I met and were joined with Deb in a task force looking at doing a national registry. And I came to learn about the Nationwide environment, where what they do is they have a program they call Learn from Every Patient, and it is that the clinicians have all decided on a set of data points about patients that they collect as sort of standard part of interaction with a patient that comes through their annual clinic, that they then they're actually able to take that data from their electronic medical record, or EMR, and move it into a research database and study it. And so that model was such a great example of what HCRN was doing. So it took HCRN about 10 years to get to that 6,000 patients. I started working with Gary saying, let's explore this. We explored lots of different ways to collect data. And in the end, Gary and their CMIO, the Chief Medical Information Officer, Jeff Hoffman, they have volunteered their time to take the common data elements, or we call it our common data model, for CP that was defined by about 30 clinicians, and to update their learn from every patient collection forms to be a standard set of forms, build it into their EMR, which is the leading electronic medical record system, and then offer it out to everybody in CPRN or people or sites not in CPRN. And so I see Wade, who's in Mississippi, and his IT folks have contacted them. We have about 5 sites that have downloaded those forms, and they're in the process of implementing them. And so what changes is where HCRN data is collected by a clinical research assistant goes and talks to the neurosurgeon and abstracts or takes information out of the electronic medical record and puts it into a web form that then goes and lands in University of Utah. Here, the clinician interacts as part of their interaction with the patient, and that interaction is with a form that's collecting data, and then that data gets, in the background, gets extracted and pushed over to the University of Utah. There's no second data entry going on. So we already have, just from nationwide alone, 600 patients in the registry. Seattle Children's is doing the red cap approach until we can get our software thing. They've got over 50 patients in the registry. As these electronic medical record versions come online, like if we can get Boston Children's Farm on, they see 2,500 patients a year. So our registry will get over 10,000 patients very quickly after we finish making this investment in time to get this piece up and going. So really what I wanted to acknowledge here, though, is the great work that Gary has done and Nationwide has done. It's really providing a key enabling technology that's going to make this capable. And it's a fundamental part. It is like a North Star for CPRN. Is like if you can't do that in the long run, you won't be able to succeed as a CPRN site if you can't get your data out of your EMR. So,
a question down here, please.
Okay.
I can probably. Can you give an example of some of the data points Nationwide uses that they're collecting, so people that may not have an understanding of what that would look like?
I can, but I'm going to let Gary do that.
Well, so it's like this. When I'm sitting in the room with a family, I'm speaking and I'm saying, how's it going? What are you doing this summer? And so on. What kinds of things are you concerned about that you want to talk about today? And as I'm going and I'm collecting information, I start clicking off these boxes. Why does this person have CP? Oh, they had a neonatal stroke. What level is their CP? 1 through 5. Are they spastic or athetoid or hypotonic? Well, they're spastic. Is it unilateral, bilateral? It's unilateral. And so there's all that kind of stuff. And as a pediatrician, for me, it's honestly not so much of all the motor stuff that we've been talking about here, because I have a phys med doc, a physical therapist, and an orthopedist who collects that data. And to me, it's all about nutrition and behavior and sleeping and constipation. Right, and reflux. And then, as soon as I'm done with the form and I open my note to write it, all that information's already there. And it says, Johnny is a 6-year-old boy with hemiplegic CP as a result of a neonatal stroke. He has unilateral spastic CP. And because there's also a note that goes to the primary care doctor, it has all this other sort of general information in it, about CP and the care of kids with CP and so on. And adults with CP too, by the way. So, but then what goes to the, what's then pulled out and goes into the database function is 6 years old, spastic, ulcer, heavy bleach, like those specific items.
That's great. Thank you.
And it's much easier to write a note that way. That's the sell to the everybody who wants to set it up. It's so much easier to write a note than to, depending on how fast you type. John, he is a 6-year-old.
So the great part of this is that there are many clinicians that hate their EMR. I need to, but these guys will go, they will go on record saying, 12 clinicians using it. 11 say they are as productive or more productive than they were when they were doing it the old way, and the other one says they're about equal. I'll give you 1 second, Deborah. Go ahead.
As I'm listening to you talk about this, one of the things that's really interesting, I'm from Los Angeles, and my daughter grew up with Children's Hospital Los Angeles. And I had a very difficult time finding care for her once she aged out. And as I'm listening to what you're talking about here, I'm thinking, and correct me if I'm wrong, they were almost creating the ability for maybe some of these care providers to focus facilitating adults for the purpose of being able to get in on the research. Do you know what I'm saying? It's like we know with children that they follow all this and can keep track of everything. But I don't know in Los Angeles other than I found a teaching hospital where I'm taking my daughter now. But it was very difficult to find a place, and I don't know if other parents have had that problem, to care for her. So I'm just wondering if this could be an incentive that maybe we might see more places open to taking adults for the purpose of the research.
I can only hope. I can't. I'm not sure that it will have that effect, but I have grandiose beliefs about what CPR will do.
We need a little more light.
Okay, it wasn't important. I was babbling.
I just wondered about consent and IRB issues for the registry, for taking this data from the medical records.
So Deborah asked about consent and institutional review board approval for this. So the approach that we've taken is what's called a waiver of consent, which is something that an institutional review board can grant if they feel like there's minimal risk to the patient, that they're not, that we're not, even though we are conducting research, there's minimal risk. And so we have so far 13 approvals, IRB approvals for the registry, and 11 of them are a waiver of consent, and the other 2 are an opt-out, which means the patient comes to the clinic and they get handed a card that basically says, we are using the data from your clinical visit for research. If you, for any reason, want your data removed, you just contact us and we remove you. Okay, I've seen a lot of questions. We have 6 minutes, and I really want to wrap on one more thing, so I'm going to encourage it to be lunch discussion, or we might have a little window to come back, if that's okay. Okay. Start holding the microphone. Okay, so we chipped away at R1 and C1. I want to talk a little bit about R2, because it is the mother load. So R2 is the one that, I'm going to read it, but it's the one that we had the most consolidated questions about. And someone's going to get R2 in front of me really quick. Thank you. Okay, so about 8 or 9 questions were consolidated, and they basically said the same thing. They just maybe mentioned other outcomes. And generally what the feedback from the group was is those outcomes were extraneous, like people care less about specificity, they care about participation. So we got that feedback, so that consolidation was good and effective for keeping our focus down. But so it says, which interventions, surgery, injections, medications, therapies, including orthotics, equipment, and training, are associated with better functional outcomes, important to the child and family, controlling for GMFCS, level, age, and comorbidity. And controlling is statisticians speak for making sure you can What was that?
Remove the bias.
Make sure you can remove the bias of those things. So this is a question, like this is what is so clear that in addition to like the power of the aging and functional decline issues, that everybody wants to know when we're confronted with so many different interventions, what's going to work best for my child? And this came out of the NIH workshop, and as I described early on, I ended up partnering with Michelle, with Diane, with Rich, with Susan, with Gary and Uni and Jacob in the second round, and if I left someone off, I apologize, in putting together a PCORI grant that basically described this. We were going to take 2,500 of all comers and gather all of the patient characteristics, all of the interventions, and key outcome measures over time and look at this. And we did okay, but we didn't score well enough to be funded. And so that's a little bit to Michael's point of it was disappointing. They gave us feedback. We responded. We narrowed the study to be about ambulatory kids that got interventions either orthopedic interventions or neurosurgical interventions, or they just had therapy. And we went back and we submitted that more narrow thing. We also didn't get funded. And, Rich and I were discussing it over drinks last night. We're still kind of frustrated by this. But we are not done, and we are going to probably need to narrow more. So I've been in a dialogue with Deb Hertz, who is a former officer I'm going to get Deborah's title wrong, but she was a program director in the Office of Clinical Research. That's where office came from, which basically manages the portfolio of clinical studies. And I said, Deborah, could you read our summary statement and look at the criticisms and say, if you were guiding us, what should we do to have NIH consider this, or specifically NINDS? And she's given us some feedback that we sort of need to narrow more. And so this is what happens with the narrowing process. And then Diane, who works in the clinical center, is helping with figuring out how we're going to navigate a discussion about, is there a narrowed version of this study that's interesting to NIH? And I know that Deborah was feeling, when you listen to her comments about how important this is, we need to leverage both there's advocacy language about talking about the importance of clinical research that's been in the last 2 years of report language for Senate appropriations bills. There'll be language again that we're working on now. So advocacy things are happening. But the goal is really to keep honing this. And I'm supposed to have a dialogue later this month with Udi and a neurosurgeon from Sick Kids named Ab Kulkarni, who's part of the HCRN, and John Kessel and Jacob Keene about, doing, like, if you narrowed it to be just focused on the surgical trial and whatnot. So it's just this ongoing iterative process of defining the question the right way for a funder, and also pushing back on the funders to some degree for how important this question is. So I just want to wrap this up to say, that's the top three. You need passionate investigators. You need infrastructure that can conduct high-quality, multi-center research. You need validated outcome measures and ways to get them both in the clinical setting and in the patient community. And we need an engaged community, and we've got that. So I really just want you to take away that the great work we've done over the last 3 months, and especially the last 24 hours, is really going to move forward, and I will commit that we figure out a way to report back in a report card kind of fashion so we can see the progress. AACPBN has an interest in this area and this question, or this researcher is studying this, and they're going to make a proposal to CPRN, or they're going to study it in some other way. I think that's absolutely critical for being accountable for all the work that we've done. And with that, I'll take one question, but it's lunchtime. Okay. One question, Chris.
As a red member group, I just want to acknowledge R2 that we talked about. We agree that
the PCORI grant that we attempted to submit and didn't get funded around surgical intervention is important, but we also noticed that a lot of the other therapies, we need to understand how they work as well. Whether we give them a wheelchair or not, they get an orthotic, and when they get the orthotic and what are the long-term consequences. So we need other protocols, of which I'd be happy to work with other people because I'm interested in some of those DME, wheel mobility, orthotics, because those are the bread and butter of what we're doing for a lot of our kids before they become rhizotomy candidates or seminal candidates, and not every kid needs it. So what do we do with everybody else? And lifelong, through the whole life, and Debbie's over there.
Lifelong. And so being able to track them lifelong, which is with patient-reported outcomes, is a critical capability that we put in place. By the way, we haven't launched it yet. We will launch it shortly. We actually have the initial studies there. Just got to get that IRB approval. We're having one last look at the survey. So, like, this stuff is actually really happening. And Christy, that's just a great example of how passionate researcher on that front who's going to drive it. And, you know, we were applying to PCORI's biggest funding opportunity, and they fundamentally prefer randomized control trials. But Christy, there's an opportunity in one of their smaller funding capabilities to pursue this. And Christy, I would encourage you as a passionate researcher to bring that question to your colleagues at CPRN and see if we can get it developed and funded. So with that, let's have lunch.
Zach, we have time to grab something before we start.
Okay. Yeah, and we're going to eat lunch, and then about 12:30, our talks are going to begin from there.
No, we're kind of leaning away from surgery. The one thing that my younger son has an issue with older son,
to be here. Paul asked me to do a short presentation to introduce to some of you who may not be familiar with the AACPDM, what the AACPDM is, and perhaps the intersection between what the AACPDM and CPRN and the kind of work that we've tried to discuss today can meet. So the American Academy of Cerebral Palsy and Developmental Medicine is a professional society that was founded about 70 years ago by 6 gentlemen. They were very stern. They represented multiple disciplines, so at least they had that foresight. And actually, it was founded in Chicago in 1947, and at the time it was the American Academy of Cerebral Palsy. This has evolved, and you can see that we're a slightly different organization today. Again, multiple disciplines. We have clinicians like development pediatricians, physiatrists, Eileen Fowler is an occupational therapist. We've had an educator as a president. We've had a physiotherapist as a president. In fact, if I counted correctly, there are no less than 5 presidents of the AACPDM present at this meeting. Dan Damiano, Chris Stevenson, Jim Blackman, Deb Gabler, and myself. I don't think I've missed any. So in the 1970s, the scope expanded beyond cerebral palsy to the full range of other chronic childhood onset conditions and developmental disorders, and the name was then expanded to include that, the DM, or the developmental medicine. So it comprises about 1,200 members. It's really North American in scope, and that's US and Canada, that has a large number of international members from lots of other countries in Europe, UK, and Australia, who are actually paying members of the AACPDM. It's very multidisciplinary, mostly healthcare professionals, so pediatricians, neurosurgeons, orthopedic surgeons, neurologists, physiatrists, but there are therapists, speech and language pathologists, occupational therapists, physical therapists,
there are biomechanical engineers, and there are educators and psychologists. So it's truly multidisciplinary. So the mission of the ACPDM is this, is to provide scientific education for health professionals and to promote excellence in research and services. And these are our ultimate stakeholders for the benefit of people with and at risk for cerebral palsy and other childhood onset disabilities. So that's what we are about, is to educate us to do this better. What we do is very well defined by a strategic plan that was initiated in 2013 for the next 5 years. This is the last year of that strategic plan. And it's a good way just to define where there's an intersection between what the ACPDM does and can intersect with what CPRN does. So the 6 buckets, if you will, were expanding the talent pool, facilitating research, facilitating innovation in learning, partnership and collaboration, service delivery and quality improvement, and organizational excellence, or just to be a better organization. So let's go through each of those very briefly. In terms of talent pool, as I said, we have 1,200 members, very multidisciplinary. So what's missing? So how many of you here are not members of the AACPDM? Okay? So some of you are parents, some of you are people with disabilities or with cerebral palsy, and some of you are actually health professionals who are not members. So maybe that's what's missing, and that's another conversation. And we should have you at the table just like we had you at the table today when we're talking about research agendas. To facilitate research, AACPDM aims to be the leader in fostering research that will generate new knowledge and evidence to inform the care of people with cerebral palsy and other childhood onset disabilities, which is exactly what CPRN is about, CP Research Network, and clearly the business of CPRN intersects with this major priority of the AACPDM. The 2 things that they focused on the last 5 years was in outcome measurement, in developing the common data elements that they did with the NINDS, which is very much in parallel with what CPRN has done, and there's a convergence there, and these common data elements are now available and can be used by centers in CPRN where they've converged with what we've developed here as well. Learning innovation, so AACPDM innovative approaches and topics to advance knowledge and practice in cerebral palsy and other childhood onset disabilities. So whatever new knowledge there is, whatever evidence there is, we have to be able to teach it to those who can implement it. We have to be able to disseminate it in a way that is accessible. So that's a major initiative, and we have to think of clever ways of doing that. So we have to be innovative. It's not just the textbooks, it's not just in the medical schools or our residency programs or fellowships and other training programs. Partnership and collaboration is huge. It was recognized that there are many stakeholders, there are many organizations, foundations, charities, industry and other agencies that are also interested in that ultimate goal for the stakeholders. And AACPDM has recognized that and wants to develop and nurture collaboration among these various agencies. And towards that end, there's 2 initiatives. One was being part of a partnership with the European counterparts and our Australasian counterparts to develop the International Alliance of Academies of Childhood Disability to provide the kinds of things that we have here to other parts of the world where that's not readily available. And that's an ongoing effort that is coming to fruition. What is relevant to this effort is that the AACPDM have embarked on a process to develop a community council that has as its members various representation from the community. So there was a summit held in Chicago a year ago from which community council task force was constructed, and it was transitioned to a community council and has for its members 13 CP organizations, foundations, advocacy groups, many of whom are represented here. Okay? Service delivery and quality improvement, we want to be able to improve the care of children with cerebral palsy and adults with cerebral palsy and other childhood onset disabilities. And the AACPDM has the resources and the expertise to translate the evidence that's out there, to put them in accessible forms of care pathways which can then be used at the bedside or in the clinic to implement programs for which we've got good evidence to support the kinds of care that we can provide. There are many such care pathways that are currently being produced, We've got one for dystonia, bone health and CP, in pyorrhea or drooling. There's one being developed for hip surveillance, another one for early detection of CP. A major annual event in the AACPDM calendar is the meeting at an international forum for the dissemination and exchange of new knowledge and ideas and to provide education to the health professionals. And we also have in the participants people with disabilities and people caring for people with disabilities whose contributions I think we value and can learn from. This year's meeting is in September in Montreal. Sarah Winter, who is the current first vice president, is responsible for organizing the meeting. And those of you who can make it, I think we would welcome your presence and your contribution. I don't know how much, if I've got a minute and I can answer questions, but I think I should.
You have a few minutes to answer questions.
Okay.
I just want to make sure, is there anyone that is unclear about what the Academy does and how, could you share about the Family Forum?
Okay. So, the Family Forum was a question that Christy Gerson raised. So, every year at the annual meeting, we have allocated a half day to a full day's time to an item on the program that we call the Family Forum.
Community Forum now.
Now called the Community Forum. And the concept is, and it can evolve, it's not set in stone, that working with the local host who has a good idea of who the community is in and around where the conference is actually being hosted, it can provide a venue for the community to be engaged, brought in, and they use that as an opportunity to share information, either get information from them or to provide information that might be of interest to them. So every year they may have a slightly different theme, but we take advantage of the healthcare professionals who are there at the meeting to provide or share their perspective, which can then be helpful to families and or the community at large in that local area.
Yeah, I was looking on your website, which is fairly easy to navigate, and I'm wondering what kinds of, I see all of the different committees and opportunities to volunteer.
She's going to repeat the question.
I can't talk about it yet. I guess I'm wondering specifically what kind of time commitment is it for volunteers, because you have a pretty extensive list of volunteer opportunities where you're looking for people to sign up.
So the answer to this question was, looking at the website of the AACPDM, there are numerous committees, and there are lots of opportunities for people to volunteer to participate in those committees. So at the moment, those committees and the participation of those committees is limited to the members of AACPDM. And the members of AACPDM today are professionals who are involved in the care of kids with cerebral palsy or other child developmental conditions, adults as well, or researchers involved with them. What we don't have yet, some of those might indeed be parents. So we've got researchers, healthcare professionals who are also parents of children with cerebral palsy, so we have their contribution. But what we don't have yet as another discipline, if you will be people like you. But for those who are members, it is entirely voluntary. So they devote as much time as they can give, and the tasks that fall under the mandate of that particular committee.
So you want to comment on the community council as a potential big.
Right. So the community council was an effort for the academy to reach out to and create a forum where all these various agencies who've got different but very complementary missions could come together so they could have a conversation. Because we all want the same thing. Some focus on research, some focus on dissemination of the information that's being generated through research, some focus on advocacy, some focus on very fundamental research, prevention, cure, others focus on on treatment and management, but we all want the same thing. So why shouldn't we be at the table, as I think it was raised earlier today? So once the community council takes a more formal role, then they will become a ongoing permanent partner, if you will, a parallel, it's not necessarily an organization, but a council with representation from the AACPDM on that council and representatives from the council on the AACPDM. I am, and this is one of my wishes, is to do more than that. Is to actually, and this is not going to be easy, I've got to convince the members of the value of this. I would love to see persons with disability and parents of people with a disability to also be able to become members to help us, not to change the mission of the Academy, but to make us do that mission even better. If you're going to educate healthcare professionals how best to provide care for people with disabilities, who's best to have at the table people who can tell us how best to do that? It's a stepwise process that we're trying to get underway.
We need to wrap up. I know there were more questions, but Jim, I think, let me check to make sure your slideshow downloaded. Thank you, Uli. I will say while I'm trying to get this to work that you didn't have the benefit of being on the last community council call, but the community council will include some members of the community in addition to leaders board, which would point to your volunteering. Where is it? Sorry, Jim, let me see. It looks like it all downloaded. Yay. So, I don't know if I made it clear when we added this, when we introduced this portion of the agenda, that both AACPDM and the CT Alliance Research Foundation are sponsors of this event, and their support has been very helpful in making this event happen. So I thank you, Udi, and the Academy, and thank you, Jim and CPAR. Where's the clicker, sir? I didn't want to take a picture. But I have your your way, and you have the floor.
All right, thank you. And I ditto with Uni's comments about the appreciation for all the effort to organize this stuff. Anyone who's been involved in organizing meetings knows it's no small task to do this. So great job. And again, I hope this is the first step of many steps that will continue the process. So Michael's comments before have been referred to a number of times since he made them, but I think of what I'm going to talk about with respect to
Jim, can you get a little...
The Cerebral Palsy Alliance Research Foundation has to do with funding and maybe another bucket of funding that'll make that more possible and help achieve some of the goals that have been discussed at this conference. And secondly, with sort of the delayed gratification challenge of some of the things that we'd like to study, we'd like to bring those results as quickly as possible to people who might benefit from them. So it's not always possible, but that's part of our mission. So the Cerebral Palsy Alliance Research Foundation, I'd like to introduce you to, because I think we would like to be a player in this family dedicated to research in cerebral palsy. So the Cerebral Palsy Alliance is based in Australia and started as the service delivery mechanism for therapies and so forth to individuals with disabilities, particularly cerebral palsy. And then a number of years ago, they decided that they wanted to include research as part of their mission and establish the Research Foundation. But the Cerebral Palsy Alliance provides therapy and services to over 5,000 clients, 55 sites across 2 of the Australian states. Their budget is close to $100 million, over 1,000 staff, over 1,000 volunteers that work in that program. And then, as I said, they developed the Research Foundation Institute. So this is a major force in the care and treatment and support of children, families, individuals with cerebral palsy. So the research arm has been very successful in Australia for raising money for research. And so the thought was, well, given the population of Australia, in the U.S. it's a lot bigger, and so it should be possible to raise a whole lot more money for research in the U.S. So about a year and a half ago, a decision was made to set up an office beginning in New York City to raise funds for research. And so it's a small staff. I was lucky enough to become the medical director of the U.S. operation, but the head of the foundation, Brian Metherall, who is a lawyer by training, but is a very accomplished development person. So we are awaiting any moment for her to tell us that she's delivered her baby. She will be going on maternity leave. And then Professor Nadia Badawi is a neonatologist, and she's based in Australia, is the head of a big NICU in Sydney, but also spends a good part of her time as the chair of cerebral palsy for the foundation. So the goals of the Cerebral Palsy Alliance Research Foundation are to find prevention and cure for cerebral palsy. Sometimes I will admit that the idea of prevention and cure kind of rubs people the wrong way, because some people feel it sends a message that the lives of individuals who have CP is not valued, and we need to prevent or cure it. But really, I'd like to emphasize that when we look at prevention and cure, it's a spectrum. So it's not only prevention of injury to the brain that leads to cerebral palsy, but prevention of comorbidities, prevention of cardiovascular disease, many of the things that we've been talking about today. So that's an important element of prevention. And cure, again, it's controversial about whether someone would want to be cured of CP. I ask this question of most everyone I meet, and I think what I found is that parents of young children are keen on cure. Older individuals, they say, I've got used to my cerebral palsy and I don't really need a cure. But anyway, there are those that are hoping for a cure. And again, cure is sort of a spectrum too. It means not necessarily complete cure, but mitigating, making severity perhaps less than it might have been without a certain intervention. So the other goals are to enhance global leadership and collaboration. So this is based in Australia, office in New York, but it's a worldwide effort for sure in terms of collaboration. We want to build a global research roadmap. So what has been discussed here is of great interest to our foundation to incorporate into this roadmap, not only for the U.S., but for the world, because some of these issues, of course, are just as important everywhere else in the world. Fund the best researchers in the world. So if we have a question or a problem, we'd like to engage the best minds everywhere we can find them to come together to solve that problem. Build careers in cerebral palsy research, bring new people into the field, and enhance the size of the pie for CP research. So we're not out to be competitive with Pedal for Pete, or certainly not with the NIH, but we feel that every dollar we can raise for research is going to help the cause. So our vision is to fund the world's best researchers to prevent and treat cerebral palsy and ultimately find a cure. So the way this has worked very successfully is that there's an annual competition for research from the field for whatever topic related to cerebral palsy that a researcher might think of. But there are certain topics that we feel, yes, with groups such as this, have identified as important areas of research. Let's bring people together and set up a roadmap for accomplishing that task. So there have been a number of these summits held. The first one back in 2011 in San Francisco to look at the state of the art in the care of premature infants. You know, what treatments were there, and what did we need to learn about better care of premature newborns. Other topics have been genetics. There was a recent conference in Adelaide to look at the research in genetics. We just had a summit in Los Angeles a couple months ago in collaboration with the March of Dimes to look. It was focused on prevention of premature birth. The March of Dimes is very interested in that topic. and then prevention of injury to the brain in the NICU among premature infants. So these are some examples of the institutions that have received funding. Since its beginning, over $30 million have been invested in over 200 projects worldwide, not only in the USA, but Europe, Asia, Australia, and Africa. So if you look at some of the institutions, NYU in New York City, Duke, Johns Hopkins, Children's National Medical Center, the University of California, San Francisco, Michigan State, so many different institutions in this country. Jody Robinson just received a grant from us for her work at Johns Hopkins. And then, of course, institutions, a few in Europe, surprisingly, there have been more proposals from Europe, but many in Australia as well. So another mechanism for moving the field along, and this gets to trying to speed up and accelerate discovery, has been this impact for cerebral palsy. Some of you have been involved in some of these meetings, but the idea is to bring together an interdisciplinary team with also representation from stakeholders, parents, individuals with CP, not maybe to the degree here, but certainly more than token representative. But the idea is to develop a shared research plan, making the search for answers more efficient, to accelerate, and this is probably the most important one, like how do we accelerate research breakthroughs, smoothing the path from basic science to clinical trials to patient practice. So we do fund basic research, but the idea is to get that through the pipeline as quickly as possible to the front line. So provide mentoring opportunities and support between researchers. So this collaboration, we don't have people duplicating their work, that we bring people together, learn from one another, and share ideas. And build momentum and bring the world together promoting international research collaboration. So these are just some of the examples. You know, sometimes we think, boy, this has been slow moving over the years. Those of us who have been attending the Academy meetings for 10, 20, 30 years, sometimes you feel like we're kind of recycling sort of the same ideas. But I think particularly in recent years, we really made a lot of progress. And just to give you a couple of examples, for example, the introduction of magnesium sulfate, which is a drug that can be given to women in labor to help protect the brain, the fragile brain of the newborn preterm infant. So that coupled with brain cooling down the brain after the brain has been stressed during delivery. Over the past 2 decades, botulinum toxin has become very widely used. So there are areas where progress has been made, and I think we are on the cusp of really accelerating many areas of research, partially because of technology and partially because we've gotten smarter about incorporating community, stakeholders, families in the discovery process. So Australia points out to the actual progress that has been made in terms of research in treatment of cerebral palsy. They have a registry, so they can provide this kind of information. It's harder for us to do this in the U.S. But comparing a study of individuals in the 1980s compared to the early 2000s, they have found that the number of individuals that are in the less severe stages of the GM-SBS has increased from 50 to 66%, whereas those in the more severe category have decreased. Now, they can't absolutely talk about cause and effect, but they believe that their coordination, their comprehensive programs for cerebral palsy treatment and research may have a part in this change. So some of the research interests that have been highlighted for this year, and it's a combination of those that have been ongoing with the foundation in Australia and those that we've taken on in this country. And you'll see, you will recognize some of these because they're what we've been talking about in the last day or so. One is with chronic pain. So I really tried to push this in terms of our priority. And here's an actual concrete opportunity. So I have just written, so I told you that we have this annual competition for funds for research, and anybody can submit proposals. So I've written a special request for proposals that relate to chronic pain. So there will be a pot of money that will be devoted to projects that relate to pain. So there's not much time because letters of intent are due July 1st, and I think grants are due at the end of August. But this is something that CPRN or others that want to use that network could tie into and apply for projects that relate to chronic pain. So the other areas that we're interested in: prematurity and cerebral palsy, genetics, regenerative medicine. It's been for a number of years a big push on use of stem cells in CP. And the reason that started with the foundation was parents were demanding it. Said, we want to know whether stem cells work, and if they do, we want to have them available. And as you know, parents have been taking their kids to other countries, Mexico, China, and other places for treatment without really knowing whether it was the right stem cells, the right administration, and so forth. We need to understand that. So we've devoted a lot of time, and probably will be devoting a lot of money to protocols that address stem cells and cerebral palsy. Technology, early detection of CP, thinking that the earlier it's detected, the better the outcome will be. Deep brain stimulation for the dystonic type of cerebral palsy. And then we put down here priorities as identified by the CP collaborative and the community. So I guarantee you, we will take the summary of our deliberations here and incorporate that. We already have with pain, certainly, but some of the other priorities, and try to push those through and make them at the head of our list. So the next thing, again, another concrete thing that we are doing to raise funds is a promotion called September. And Lizette, who is now on our, this is Australian speak, our board of governors for the foundation recently, will tell you a little bit about this initiative and the potential for you to be involved.
Thank you. Thanks so much. All right, so I'm going to make this quick, but an overall theme that I heard discussed today and by Dr. Michael earlier was talking about none of this stuff is possible without funding. So this is really quickly to discuss September program, which is how the Australians at CP Alliance have been so successful in raising hundreds of millions of dollars that has all gone back towards CP research. And I know all of us in this room feel very passionate about research happening in the United States, and this is a very easy way to get involved and to have some of those dollars come back to our community here in this country. So first of all, September is a global fitness challenge. So it's a fitness challenge that benefits CP, but it is not like a CP-related program. And what I mean by that is it challenges people to sign up in teams of 4 people, so you can get just a couple of your family members or friends, and you log into the September website. Basically, you pay $25, I'll get that next in a second. They send you a pedometer that you put on your wrist, kind of like one of those Fitbits that everyone has, and you log your steps every day for 28 days, and you get people that kind to sponsor you. So this, unfortunately, isn't working, but it was a quick little TV campaign. So you guys may see across the country.
I may be able to get it to work by tapping on it.
Really? Okay, because we couldn't get it to work when we got it, but maybe. Oh, here we go.
Have audio, I can turn audio on, but you're not going to be able to hear. Here, can you have that? I have to get here. Can't hear. They can't hear.
But basically, this is telling you to make a change. So instead of sitting on the couch, right? I know, right?
I would like that.
So you all may see these commercials in a city near you, and also some radio campaigns. CP Alliance is really putting a lot of money behind this year, and the reason is that they know that this program is so successful in Australia. This is where they've gotten their money to do these incredible things that they've done. So let's see, my clicker. Oh, here we go. Okay, so I already said it was created in Australia. This campaign now runs in 8 different countries. They starting this year. Last year was kind of a soft sell. So now 2017, a big push. So money raised will support CP research exclusively to accelerate prevention and cure. And you all already talked about the teams. This is the big thing right here that CP Alliance is doing, and I think this impacts all of us in this room, is if you all decide to get behind this and do this and go to the website, and it's very self-explanatory, and decide to have your own team, if you put in this registration code, the CPC Collab 2017, when you register, those dollars you raise, let's say you raise $100 and collectively in this room we raise, let's say $40,000, which I think is possible, that money will then be earmarked, and the collaboration will have a say, everyone in this room, as to where those funds are spent. So I think that's really important to know. Again, it's $25 for adult and per child. It's a great, easy way to actually say I'm doing something, and it really doesn't require a lot of, commitment, let's say. All right. Thank you.
Thank you.
Oh, yes, one last quick thing, sorry. If you all are part of a large company, let's say you work for a very big hospital network that you think you may be able to influence and get behind September, then please you can even contact me or contact Jim, and we'll get you in contact with Susan Wilson, who will just take over the lead and hopefully sign on the big institution. So, because that's really the way that they make the most bang for the buck. So, that's it.
Why don't you just open it? I wanted to give you a chance to answer a couple questions. So, we take a couple more minutes. I saw a hand go up, Poonam. Actually, Poonam, I'm going to let them repeat your question, so go ahead and say it.
I was just going to let Liz know to especially mention the matching program, because that doesn't meet the corporate match, but it's like one-on-one kind of thing.
You're right. That's so true. For all of you all, a lot of people, I know my husband's company, whatever we give, if we give $100, let's say, to CP Now, and if we submit a form, which I need to do, then they will match that dollar for dollar. And a lot of you all may work for companies that offer corporate matching. So please look. It's a good way to double your money.
Any other questions or a couple other questions? Go ahead, Claudia.
I don't need the microphone. Can you repeat, though, what that CPC something.org?
Let's read it up here.
I can't see it.
It says CP Collab. Okay. So CP Collab 2017.
Thank you.
And so there's a reference here that Michelle and I have realized has come up a little bit called CP Collaborative. And relative to the advocacy things, it's worth just taking a moment to explain. So there's been a lot of, what's that?
Particularly in response to Daniel.
In response to Daniel, okay. So one of our friends in the community, Jennifer Lyman, was very passionate about getting, there are many, CP is fragmented in terms of advocacy and boards for a number of reasons. And Jennifer Lyman, who has a son with CP, was very passionate about getting the organizations to collaborate. And so she created what's called the CP Collaborative, which is, there's many of the, all of our organizations that are represented here are part of it, and it gives us a way to connect with the community to collaborate on anything from advocacy to research or whatever. And it's, so it's an available website, cpcollaborative.org, and you can go and look at that. Or, but anyway, so that's what the reference to the CP Collaborative is. Okay, one last question. Any other questions? I thought I saw another hand on this. No? Okay. All right. Well, again, thank you, Jim and Lynette, and the CP Alliance Research Foundation very much for your support. Thank you, Uri, and to the AACPDM for your support. We greatly appreciate it. All right, let me get back to my wrap-up slide. Okay, I'm going to move this to one. Okay, so I'm going to just discuss logistics and then go to our wrap-up, and we're actually going to land the plane a little bit early. Get out of the way of the screen, I am told by Hillary. Okay, so first, for community members and people that had travel compensation to this meeting, we need you to submit expense reports similar to what you did for your air travel. So same process, no change to the process, correct, Michelle? So take your receipts and please get all of your expenses in one invoice, please.
Off the template, we'll send it out.
We can resend the template just as a reminder. Yes. Kathy has a question.
U L T I multi T E multiple? Yeah. Multiple. L I N L-I-N E-S, multiple lines? Yes. Yes.
In the spreadsheet?
Yeah.
Yeah, you can have multiple lines of expenses?
Yes.
So
You can email me if you have any questions. You have my email. She has my email. Yeah. Is that okay?
Okay. Great. Okay. Then there are stipends for the community members, and we just want to let you know that from a process perspective, Precori's a wonderful organization. It's very slow to pay. So they are covering the cost of stipends, and they have not refunded the travel expenses yet. So Michelle is floating all of that, and they've come up with 2 contract changes that they've recommended that would allow them to help us, but they're wrong. So anyway, so stipends will be paid after the release of the first set of expenses for air travel to Michelle's organization. She'll be in a position from a cash flow perspective to pay the stipend. So you don't need to take any action. We know who's here. We'll follow up with that. Those checks will be cut as a function of Precori living up to their side of the contract. We don't doubt that they will do that. We just doubt that they are fast about doing it. Mary Kay, feel free to use your connections and give a little bit.
They always reimbursed me immediately when I was on that side.
So then, in addition to my thank you to AACPDM and the PP Alliance Research Foundation.
Hours.
What's that?
Hours.
Hours, yes.
Hours. Thank you.
In addition to our thank you to Michelle, President and founder of PP Now, who has got the grant that's funding all this. She's reminding me to use the our word. We want to thank all of the clinicians and researchers that were able to pay their own way to come here. I know that many of you have departmental support. Maybe some of you were just generous. Whatever it is, we greatly appreciate it because it's another element of what enables this workshop. So we really don't want to let the day pass without thanking you for your support in getting here. We hope everybody got a ton of value from this, but we really appreciate your willingness to do that as well. So say? I should be using it.
It's over there on the
I don't really use it. Okay, so I want to respond a little bit to takeaways, and I'm going to give you a little preview of something and get myself into trouble, but I'm going to do it anyway. So the number one takeaway, in terms of the one that had the most votes, was how are we going to look at things longitudinally? And as I talked, we've got these two registries that are part of CPRM. We have the clinical registry, and you heard a description about some of the complexity about how we're capturing data out of EMRs and whatnot for that. But there's another registry that is being launched as part of a web portal. A web portal just is a website where you can sign up and give a profile. So, and it is called mycerebralpalsy.org. It is owned and run by CPRN, but what it's intended to be is a way for the community to come together on these issues of research, to participate in the registry. And so one of the things is it is going to be launched first with some adult-oriented longitudinal measures. So they're in the form of surveys. There's one about pain. There's another about social and emotional issues. These are in the portal right now, so if you go to this site, you can log in and you can you can do the consent and do them, but we're throwing away all the data because we don't have the IRB approval. So we're in test mode right now. And you can feel free to do that and email me with any feedback about, things that are not clear, if it's buggy in any way. But the intention for that is it's not only a gateway to access these validated measures that can be done annually, but also will be a place to kind of track the progress for this project overall. It's a place to allow the community to come together. We have not launched any kind of communication or sharing elements. Right now it is a blog or place to place, information about updates about research, and a place to see what studies you can participate in. But the intention is to give you a private place, so it's a place where you fill in a profile, but none of that information is shared. And then you will have an opportunity to participate in dialogue if you want, but the default is it's entirely anonymous. You're sharing data with the University of Utah for these longitudinal studies. So this, in my cerebral palsy, is bigger than the community registry, but it's where the community registry is going to come into fruition, first with adults, and it is very focused at this number one takeaway we had, that we really need to focus on longitudinal with validated measures over time. And the idea will be, we've had a discussion, we have two study groups working on this, one that's working on adult measures that put together these first set of surveys. The second is a set that's looking at pediatric measures, and so we've decided we're going to use a measure that's called CP Pro. We've been working with Boston University to get the licensing in place that we need to be able to run that. And then what we're going to be doing is taking for all these measures. If you join this, we will basically annually encourage you to take this, these measures, and so we will be able to measure quality of life, participation, things like that over time. We'll start now, but we'll also be able to take the kids that come into the registry, into the clinical registry, have parents be able to, your parents can create an account and can report on their children, and then the children will eventually be able to take their profile as they become an adult and carry it on. And so if you're in a pediatric institution that's in the network, you graduate from that institution and go into what Gary referred to as the Wild West. We're going to be able to have that tether to you so we can keep tracking in the interest of solving this fundamental problem. So mycerebralpalsy.org. Don't, if you're on some forum or on a Facebook page that's about adults, please don't share this yet, but you're welcome to sign in and test to get feedback. Any data collected is thrown away at this stage. In terms of outcomes, we know that this is a critical thing to collect outcomes about participation. And that will be an area we will focus on. I was talking to Uni, and he was talking about the fact that there are validated participation outcomes, but nothing that gets to the your specific severity level. Was that it, or was it not?
Just go around the table and ask each person what they mean by participation, and it would be very different.
Right.
So we've got to go to kids with CP, teenagers, and parents, and ask them what they want.
Yes.
So I will say that Uni is one of the people on this pediatric group, and so this is an area of focus, and Jacob has expertise, a measurement expert in this, so this is an area we definitely take as a key thing for CPRN that we will take forward, and it will manifest itself in the through the portal of my cerebral palsy. And because it's going to eventually allow you to not only watch what's going on in research, but have a dialogue about it, is what's intended. It's a way to keep the momentum, which was so many bits of feedback to say, how can we stay engaged? So we've got the community advisory committee that Michelle runs as part of CPRN, and we're willing to take names as future participants in that, but this will give us a broader way to keep an engaged dialogue. So sign up, look for that there. That's a way that you can continue to contribute. Michelle, you can say more than one thing. Go ahead, Michelle.
I just want to say, if anybody in here wants to know how they can get involved and what might be available, not just with my organization, but community-wide, I am happy to have you contact me, and I can tell you what opportunities exist for you to put your energy into, and whatever works for you. No, Amy.
I don't need a microphone. But the other way that you can get involved, you've been here, you've heard all the great things that are going on.
Sorry, we do need a microphone.
Oh, sorry. Well, then hurry up down here. Yes, you do. Really fun. Another way you can get involved is to go back to your hometown, to the facility where you get your care, and ask the facility and your caregivers there, are you a part of any of these organizations? Are you a part of CPRN? Let me tell you about what I went to over the weekend, because that's who they're going to listen to. We're all at our sites doing this, but really, truly, if you go back home and you go to your caregivers and your providers and ask for them to get involved in these efforts, I think it will do a lot. Thank you. I'll run the microphone wherever it needs to go.
Yeah, that's okay. I was going to, just because you said that, go away. There you go. Come on, Taskforce, go away. You're in my way. Ed Hermits would be going crazy. Okay. I like to have a slide for everything. These are the sites that have committed to participating in CPRN. I've got Texas Children's up there because they're actually are just making steps, and then actually so is called UT Houston is also taking the steps to do that as well. So to Amy's point, ask your clinician. Go ahead.
If we go to some hospital, but we get only a part of the care there, is that data going to be sent to you or no? Just because the diagnosis, will it come to you?
Well, so if they join CPRN,
the question.
So the question is, if we go to a center that, we only get part of our care there, it's not like, a multidisciplinary clinic or whatnot, would that data move to CPRN? And the answer is, so many CPRN sites are not capturing data for a full multidisciplinary. Some are focused, they either only have strengths in certain areas, or they don't have the coordination to have, say, their neurosurgeons may not be involved, but their orthopedic surgeons are involved, or their neurosurgeons, or pick any discipline. And they're CPRN sites. So we're not getting a full complement of data for them, but we do insist that we have the sort of core demographics data that would include things like diagnosis. So yeah. And the follow-on question is?
Let me rephrase it. So, and I'll use our example.
Yep.
So we go for physical therapy to UNC, and we go for eye care, eye specialist to Buffon Hospital for Children.
Yep.
So we are seeing different disciplines than the PI who may be in your network for CPRM. So, but both these disciplines that we see capture the CP diagnosis on the treatment that they offer.
Right.
So is it possible then to get that data to come to you even though it's not being seen by the PI?
So the question is if the person is being seen at multiple institutes and not a place where our principal investigator is collecting data, can something like the diagnosis move to us? There's not a mechanism today. There are plenty of things that are. There's this thing called the blue button, where there's a push to make it so that electronic medical records should be exportable and moved. There may be that in the future. I tend to not focus my energies on things that are that far off, so there's no mechanism today. Okay. Go ahead, Amanda.
My question's for Amy. Will we see Cincinnati Children's on there soon?
We are working on it, so it would be really helpful if you would go to the people that you like to give feedback to. We have been in discussions with our IT. We've looked at our EPIC. They are aware of my involvement in it, but it would be really helpful if you could spread the word and advocate for that. I think it could be quite powerful.
So Amy was answering the question is, are we going to see Cincinnati Children's on there and heard by the backers, please advocate for that. And I will say that Amy has been part of CPRN from the beginning, and we have had numerous discussions. It is not an easy thing to get an institution to do the work to include the electronic medical record data collection. It's easier in some places than in others. I mean, I think the next site that will be up and running with EMR-based data collection is Children's of Colorado. And AI DuPont and Texas Scottish Rite will probably follow, and then Wilson and Jacksonville. So it's going to take time, and then once we get there, it's going to be a glorious thing. So Amy is working really hard at that, and she is a critical leader in CPRN. She leads our whole quality improvement effort, despite the fact that Cincinnati has not been able to commit yet.
One thing that I know will happen is, as Paul always says, there's early adopters, and then there's mid-early adopters.
Early majority, late majority.
And then there's that tipping point in the ladder. So I have no doubt that, a lot of places will come on, but they don't want to be the first ones, and, they might be involved in lots of other networks that are doing registry-type work, and, so those are the kinds of things. So we'll get there.
Tell them Columbus is doing it, and sometimes that competitive fire.
I think they know Columbus is doing it very well.
Columbus is still a little too far for me to head up there.
Sometimes I can get things done if I say, down in Cincinnati, blah, blah,
blah. Same thing in Seattle. If we say Nationwide is doing it, or Cincinnati or Boston Children's, we get things moving in Seattle, too. There's a little bit of competition.
Competition is good. Go ahead.
So, I know Amy Dale said that when you go back, get your organization sign up and all that. So, can it also be done through the local primary care physician offices? Or
so the question was, can it be done through the local primary care physician offices? And it cannot. We don't have a mechanism where, the overhead is such that it's really focused at centers. So when we get, Cincinnati's annual patient load is somewhere on the order of 2,000. Boston Children's 2,500. It's we're looking for the. I know that you're very individually about capturing the data for your kids, but what we're trying to do is get big centers or as many centers. They're not all big, but with that automated process, because it's what will really enable most capabilities. Okay, so I was looking at our query application as we were wrapping up to see how we get. Oh, by the way, I got hot and I took off my shirt, and I just have to share my. We actually had a meeting in March 2016 of the leadership team upstairs here that Oni was at, and Amy was at, and Gary was at, and Jacob was at, and Susan couldn't make, and Jerry Oaks, who was our neurosurgeon representative, was there. So these were the T-shirts for coming. I'm a cheap date, just so you know. Okay, so these were the 4 objectives that we listed in the PCORI application. So conduct a series of online webinars to educate patients, caregivers, and clinicians about clinical trial design and comparative effectiveness of research, patient registries, patient-reported outcome measures, patient-centered research, and the state of publicly funded research, collaborative research, and quality networks. Check. Build and distribute a survey for the patient and provider community to provide input into research priorities for CP. Go digital is more than a survey. Wow, it's more like an addiction. So, convene a workshop to study comparative effectiveness research agenda that synthesizes the patient and provider survey and then establishes an engaged team of patients, clinicians, and stakeholders. I think you guys are pretty engaged. Check. And what's left to do is publish a white paper outlining the community shared comparative effectiveness research and quality agenda for CP. So the quality things, as I said, we didn't discuss here, but we're going to publish the results of that as well. And so the next steps are the planning team is going to refine these the things that we did to get them into fully written forms rather than the columns, and we'll circulate those based on the breakout. So to kind of take each of these to have a concept written as it was discussed. And the team, including Sheila, our scientific writer, is going to document the process and the results. And then we're going to seek, after we're done that, to publish that in an appropriate journal, so we'll get broadly recognized. We'll disseminate it broadly with researchers. Hopefully we'll get more and more opportunities at AACPDM to get that out. AACPDM has committed to the dissemination of this information. So we'll share that broadly. And then, as we described today, we're going to use this as the basis for developing the CPRN study. So you're invited to participate to help advance this agenda, and that's by joining the community registry by going to mycerebralpalsy.org. That's the thing, but you can actually go and sign up now. As an extension to our community advisory committee for those people that are members of the community, or as clinical investigators or clinical researchers by joining CPRN, or advisors to CPRN, because I have Diane and Deb Hertz here, Diane Daviano, who are advisors to CPRN and have made themselves available to consult with us. And question for Mary Kay?
I want to add one quick thing to the disseminate with researchers. Can you add disseminate through parent advocacy groups?
Yes, we do intend to do that, but I can add that. And so with that, I want to, and Michelle would like to, come over here, Michelle. We would like to thank you very much for your time and efforts for this. We hope to turn this into a Thank you all so much.
Thank you guys so much.
Yeah, travel. All right.
Yeah.